Good evening to everybody, and welcome to today's program, which will be conducted by Dr. Karthikeyan. And we have two eminent speakers, Dr. Vinod and Dr. And we are very happy that our president, Dr. Lalicha, and our secretary also could join us in spite of the being in different places and not in India. But I request our president to please give the opening remarks, followed by Dr. Uttam Mete for his remarks, and then I hand over the program to Dr. Karthikeyan.
Good morning, everybody. Good evening, everyone. I welcome you all to this wonderful focus program on varicocele, and I must compliment Dr. Sujata and andrology team for working out a very nice scientific program, because this is something where whatever time number of things we are reading, we are always confused for certain things about what exactly we should do or not do. And many times the things go on a different line than what it should be. I am sure after this, we all will become wiser and would be grateful. Thank you very much.
Thank you, sir. Now I request Dr. Uttam Mete to please offer his opening remarks.
Hello, good evening, everybody. And congratulations, Dr. Sujata, once again for this smart learning program. It is really smart learning. And definitely, I must congratulate the convener of this program, Dr. Karthikeyan. And we have two eminent speakers, Dr. KV and Priyank. In my younger days, when I started my career, I was also interested in andrology and infertility. So we had done a little bit of work. I've done a little bit of thesis like angioembolization for varicocele, though it is an unpublished data, but it does work. And definitely, it is a common topic, but most of the time we get confused. We are not sure what to do. Say, for example, adolescent varicocele is asymptomatic or little bit symptomatic, or whether varicocele is the cause or something like that. So I think the experts like Dr. Karthikeyan or Dr. KV or Dr. Priyank, they are going to clear all those issues. And I'm sure whoever has joined today are going to be benefited with this focus program and many more programs to come from ISU USI. Thank you once again for inviting me for my opening remarks, and see you all in USICon 2025. I must just inform you that the abstract submission has already been opened. So please encourage all your PGs to submit the abstracts for Chennai Conference 2025. Thank you very much.
Thank you, sir.
Hello.
And now I hand over the program to Karthik. Please go ahead.
Thank you, sir. Thank you, madam. Thank you, Lalicha sir, Uttam Mete sir, Chavla sir, and Sangeeta madam for this opportunity to convene this program on varicocele. So I invite Dr. Vinod KV sir and Dr. Priyank for their expertise in this topic. And we are going to have two major subdivisions today. So the first part will be to understand varicocele in male infertility. So Dr. Vinod sir will be talking about basics, pathophysiology, and indications of surgery. As everyone all know that Dr. Vinod KV sir is an eminent uroandrologist from Trivandrum. Sir is the treasurer-elect, and we have been hearing sir in all the meetings. So it will be a very good time to listen to sir to understand the basics, because sir is so good at explaining things. And we have Dr. Priyank, who is eminent urologist from Mumbai. He works as a AP in the BOL Nair Charitable Hospital at Mumbai, and also is a practicing andrologist at multiple locations. He is well versed with the latest of andrology, and he will be talking about treatment options like microsurgical varicocelectomy, when to do sperm freezing, and adolescent varicocele, and special situations like azoospermia, etc. So I invite Vinod KV sir to start the proceedings. Thank you, sir.
Good evening, respected President Sab, Dr. Licha, Dr. Uttam Mite, Honorary Secretary, and Dr. Sujata Patwardhan, the ISU Chairman. And first of all, I thank USI for giving me the opportunity to be in this platform, sharing knowledge with all our younger colleagues and sharing our clinical experience. So varicocele, as all of you know, is a very important topic in andrology, especially in the male infertility. In fact, varicocele is the most important topic in male infertility because the most of the procedures are on varicocele, are centered around the varicocele. But for an andrologist, varicocele is important in another aspect because it is the most controversial topic. So we all know that it's a reversal of blood flow within the internal spermatic and cremasteric veins. Even though it was first described in 1843 by Curling, and the first varicocelectomy for infertility was done by Tulloch in 52, still the controversies are looming around this subject. If you look at my slide in the incidence, what does this slide tell you? The general population, you have 15% of males with varicose. That means it is a significant number, and most of them are fertile. So does it mean that varicocele has nothing to do with the fertility? No. If you look at the infertile group, 19 to 41% of them are having varicocele. So it has some role or a significant role in infertility or contributing to male infertility. It doesn't stop there. If you look at the third figure I have pointed out here, in secondary infertility, that is after one child's birth or after one abortion or something like that, after one pregnancy, if a male is having a secondary infertility, the chance is 70%. The 70% patients of secondary infertility is having varicocele. What does it show? It shows that varicocele is a progressive disease. If a man is having varicocele, he is having a first kid, but for the second kid, he is not having a facing infertility because of the varicocele has progressed and affected his fertility. Now you look at the fourth data I have given. At the age of 6 to 9 years, if you look at the incidence of varicocele, it is nil. What does it show? It is not something which is coming congenitally. It is an acquired event, because in adolescence, it comes to 5 to 30%. That also shows something else. What it is? In adolescence, even if there are 5 to 30% of incidence, that much patients are not having infertility. So even with looking at the incidence, you know that how confusing it is. It is a significant element. It has a significant contributory element to infertility, but we are not sure how far it is significant or which all patients need to be treated, or are we over treating these patients? So let us try to unravel this confusion one by one. So before addressing the pathophysiology, we should know why it happens. Why varicocele happens? There are three main reasons which are proposed, which may not be the reason, but these are the three reasons which are proposed. One is the left testicular vein insertion is perpendicular. But on the right side, it is oblique directly into the IVC. So there could be some pressure which is tracking down from that renal vein. It is one of the reasons. That is why more varicoceles come on the left side. Second postulate is it could be the absence of competent valves. And third is a nutcracker effect. I will show that. So here we can see that the gonadal vein, left gonadal vein going and joining the renal vein in a perpendicular fashion, and on the right side you can see it in the oblique fashion. So that is one of the reasons. Second one is the absence of competent valves. Third one is the nutcracker syndrome, which is very commonly described. It's a superior mesenteric artery going above the left renal vein and compressing it against the aorta, producing an increased pressure in the renal vein, and that is contributing to the varicocele. These are some of the explanations given to the etiology of varicocele, and that is why we are seeing more of left-sided varicoceles. So if the varicocele, if at all it happens, what is its impact on the spermatogenesis, or what is its impact on the health of that male testis? So before going into that, we should know what is the normal physiology in a scrotum. Why the testis is kept outside? We all know that the testis is kept outside to reduce the temperature inside in the testis. How it is made? It is by the countercurrent heat exchange. You may be familiar with these pictures. The countercurrent is just like what happens in the kidney. You have the hot arterial blood coming to the testis. You have the hot arterial blood coming into the testis, and the cold venous blood going from the testis to the heart. So there is an exchange of heat which makes the hot arterial blood cold, and the temperature comes down. That is a countercurrent exchange. So the varicocele actually disrupts the countercurrent exchange. So our first possibility, first theory of damage, testicular damage, is hyperthermia. So if the countercurrent heat exchange, when it is disrupted, it produces hyperthermia. So why this hyperthermia is producing a problem in the testis? That is our next question. There are two possibilities which can happen, and it is proved by our studies also. One is the heat affects the androgen production. So what is the proof for that? If you look at the cryptorchidism or a testicular hyperthermia, which we create artificially, or in recreational heating situations, there are some recreational heating of the testis happening in some recreations. So all these groups, if you look at them, they all impair 7 parameters. So this can even be used for contraception. Testicular heating can be used for contraception also. I'm not telling that it is a method of contraception, but it is being studied for that. So heat affects the androgen production, and secondly, heat increases the germ cell apoptosis. If you look at the cryptorchidism and varicocele testis, if you look at compare the histology of both, there are similar changes. So heat affects the testis in 2 ways. One, it affects the androgen production, and the second one, it increases the germ cell apoptosis. But do we have an evidence to say that this scrotal temperature produces a problem for the testis? For that, we need to prove that the scrotal temperature is increased in varicocele. We need to prove that, but the evidences are weak. Even in animal studies and in human studies, the evidence is weak in proving that the scrotal temperature is increased in varicocele. Why it is weak? Because some studies show a positive impact. A second group of studies shows there is not much increase in the temperature. And second option is to prove that scrotal temperature normalizes after varicocelectomy. There also the opinion is divided. Our findings are on both sides. Why this happens? Is it because it is not happening actually? It may be. The scrotal temperature may be increasing, but we are not able to prove it because the scrotal temperature varies with the body position and activity, and it is very difficult to prove it. Now, the second possibility of testicular damage is due to increased venous pressure. Whenever there is a varicocele, there is increased venous pressure. So what is the impact of increased venous pressure? It reduces the arterial inflow into the testis. Secondly, it causes a stasis and accumulation of toxins which alter the temperature. So these are the two mechanisms which can be the sequelae of an increased venous pressure. Both these can produce a damage to the testis. So do we have a proof for this? If you are looking at the animal studies, we can see that when there is an artificial varicocele created, in some of them the arterial blood flow is increased. Is it helpful? No. Even increased arterial flow is damaging to the testis, because when there is increased blood flow into the testis, the countercurrent mechanism is again damaged. More hot blood is coming into the testis and it will damage. In human studies, on the other side, we are not able to prove that there is a difference in the blood flow. It is just because of our experimental inadequacies. So the second possibility is increased venous pressure, and third possibility is a hormonal imbalance. So which are the hormonal imbalances we are looking into? Primarily, it is the testosterone levels, whether it is increased or decreased. Secondly, the sertoli cell function, and which it will be reflected by the inhibin levels and the blood testis barrier disruption. So there are three areas where the varicocele can produce damage. One is the changes in the testosterone level, second is the sertoli cell function, and third is by varying the inhibin levels or breaking the blood testis barrier. In animal studies, we have been able to prove that there is low levels in the serum and intratesticular levels of testosterone in animals with varicocele, in rat studies and even in canine studies. But in human studies, in some of the studies, we could prove a low levels of testosterone, but in some of the studies, it is shown that it is not at all affected in varicocele. There is no change in the testosterone level. But one thing we have to note is that even if there is a low levels of testosterone in the group with varicocele, almost all the testosterone levels lies within normal limits. So we are not very sure that whether the testosterone levels are affected, are changed, or it is lowered by the presence of varicocele. One interesting study done by WHO shows that in men over 30 years with varicocele, the testosterone levels are lower compared to men with under 30 years with varicocele. That shows that the varicocele is a progressive phenomenon, and it has some effect on the testosterone levels. So these are all indirect evidences to show that there is a hormonal imbalance happening in varicocele patients. The fourth one is the toxic substances. Due to the accumulation of blood, there can be toxic substances as well as reactive oxygen species coming into that testis or pulling in the testicular milieu and destroying or inhibiting the spermatogenesis. So now we know what are the causes for this varicocele and how this varicocele is impacting on the spermatogenesis in the male patient. Now we want to go to the clinical examination part. What are the main things you will look into in the clinical examination? It is a very simple examination, as we all know, because it is a very superficial organ. But most of the clinicians fail to do all this, and we may miss a varicocele, or we may not diagnose a varicocele. Why? Because for varicocele examination, it has to be done always in the standing position. It cannot be on the lie-down position. You will definitely miss the varicocele. And if you're seeing a bag of worms feeling or a dilated vein, it is very easy to palpate for any urologist. And you may try to grade it. How to grade it? Grading is very simple. If you are palpating a varicocele at rest, it is grade 2. If a varicocele is visible and palpable at rest, it is grade 3. And if it is a Doppler detected varicocele, which is a subclinical varicocele, which may be seen only during the Valsalva manner, it is grade 1. So it is grade 2 is palpable, grade 3 is visible and palpable, and grade 1 is subclinical. Now, one important thing you should not miss when you are looking for a varicocele is the testicular size assessment. A difference in the size of the testis or a reduced size of the testis is very, very important in your planning of management. Now comes the controversial topic of Doppler evaluation. Most of the patients will come to your clinic or walk into your clinic with a Doppler result because it may be previously seen by another infertility specialist and they might have done a Doppler evaluation. Now you want to know whether a Doppler has to be done, or suppose a patient is coming to you with the infertility, you have detected a varicocele, do you need to send the patient to Doppler examination? It is a dictum that even all guidelines vouch for it. Scrotal ultrasound should not be routinely performed in the initial evaluation of the infertile male. There is no doubt about that. It is not a necessary investigation for varicocele, for detecting a varicocele or ruling out a varicocele. Maybe you can use it for some other purpose, but for clinical uses, it is not at all needed. But there are some situations you will definitely do it. When you have a bulky spermatic cord, like an infected a chronic infection or a lipoma of the cord, or a difficulty in palpating the scrotum, because some scrotum may be very thick, or in obese patients, and the testis may be at a higher level, you are not able to palpate the cord, or your patient is not cooperative, he's not permitting you to palpate the cord, things like that. There are situations like this which will come. And in such situations, you may be able to send the patient for an ultrasound. Now, if you're sending an patient for an ultrasound and he's coming back with a report, or a patient is coming first to you with a report, what will you do? The first thing you will be looking into, or patient will be interested, is looking at the grading. So the most clinically accepted grading is the Sartesius classification, and it is very easy to grasp that Sartesius classification, because it has to be looked into two parts. One is reflex only during Valsalva, that is grade 1, 2, 3. In grade 1, 2, and 3, there is only during Valsalva. In grade 1, the reflex is only at the groin level. In grade 2, it at the proximal segment, and grade 3 at the distal segment of the paminiform plexus. So grade 1, 2, and 3 are very simple. It is not equivalent to grade 1, 2, 3 of the clinically palpable varicocele. It is a reflex only thing. Only the grade 4 shows a spontaneous reverse flow, which is increased in Valsalva. And there may be or may not be a testicular hypertrophy. In grade 5, there is a resting reflex, which also increases in Valsalva, and there is testicular hypertrophy. Now the question is, what are the controversies around, which is in the radiology circle, about detecting a varicocele? The problem with detecting a Doppler detection of a varicocele is, depending on the patient's position, whether he is sitting, standing, or supine, and whether it is measured at the rest or during Valsalva maneuver, or the location of the vein, if he is palpating near the groin, in the distal proximal segment of the spermatic cord near the testis, the size of the veins will keep on varying. So what will you do? If you are getting an ideal Doppler report, it should mention all these things. How they have examined the patient, whether at rest position, or in the supine or standing, or at the site of the measurement of the veins. So this all has to be mentioned documented in the report. And what is accepted for definition of a varicocele is measurement of the largest vein, wherever it may be, measurement of the largest vein with the patient in upright and during Valsalva. So this is this is a recommendation for measuring the size of the veins. And the maximum venous diameter of 3 millimeter or more is diagnostic of varicocele when measured with the patient in this particular position. Upright, Valsalva, wherever it is, more than 3 millimeter is considered as a clinically significant varicocele. Now coming to the question of venography. Will you do a venography? Very, very seldom. Many of the andrologists may not have done a venography. But venography comes into picture when the radiologist is very actively managing a varicocele. He wants to do a embolization. Venography is a must. And if you are doing a varicocelectomy and the patient is having a recurrence and you want to send the patient for a or you want to further evaluate the patient, you can do a venography to see whether there are any collaterals which has come up or any veins we have missed. So venography is mostly just during a therapeutic procedure and not as a diagnostic procedure. Now coming to the treatment part. We all know that there is no medical management which is effective, and the treatment is varicocelectomy. Now, what are the indications for varicocelectomy? This is the ASRM and AUA guidelines in 2020. I will read out it because it is each and every point is very important. The surgical varicocelectomy should be considered in men attempting to conceive. It should not. It is not in a random man. This man should have an attempt to conceive, and he should have a palpable varicocele, not a Doppler detected varicocele, and he should have an infertility. And there is a proved abnormal semen parameter, except azoospermic. It should not be an azoospermia also. All other abnormal semen parameters. In such patients, you can do. So there should be an attempt to conceive in an infertile male with a palpable varicocele and an abnormal semen parameters. They are candidates for varicocelectomy. The azoospermia and varicocelectomy is a controversial topic, and I think Dr. Priyank will be dealing with that. Now, the second point, in the AUA guidelines, clinicians should not recommend varicocelectomy for men with non-palpable varicocele detected solely by imaging. So that proves that Doppler ultrasound is not at all a thing which we need. And for men with clinical varicocele and non-obstructive azoospermia, the couple should be informed of the absence of definitive evidence supporting varicocele repair prior to ART. This also, I think Priyank will detail about it. But at this level, the first part, the indications has to be very clear for everybody who is practicing a varicocelectomy. Now comes the question of special situations. Do you do a prophylactic varicocelectomy? This comes into picture. This is in AUA 2024 guidelines. They have been given this point in the previous guidelines also. It's not a new addition. In adolescent varicocele, do we need to do a varicocelectomy? Because it is a prophylactic thing. It's not a treatment because the patient is not having an infertility. A documented testicular growth deterioration or abnormal seminal analysis is mandatory to do a prophylactic varicocelectomy in the adolescents. Otherwise, you don't know that, you may not know that you will be over-treating a patient because the patient may be having a varicocele, he may not be having any problem in the fertility, so you will be unnecessarily treating a patient. So unless there is a documented testicular growth deterioration, an asymmetry of the size of the testis, or an abnormal semen analysis, you should not do a prophylactic varicocelectomy. Now there are 4 other situations. I'm not going to the details of each one of them. Varicocelectomy in high DNA fragmentation index. In such patients, there are some group of andrologists favoring a varicocelectomy because in such patients the semen parameters may be normal or the borderline, but there will be high DFI. And in such patients, you may choose to do a varicocelectomy, but it is optional. And in some of them, the abnormal semen parameters, even if they are planning for an ICSI or an IVF, you may some of the clinicians argue for a varicocelectomy because it improves the ART results. And in hypogonadism patients with varicocele, a repair of the varicocele may be help-free. And in non-obstructive azoospermia, if you are planning for a sperm retrieval, you can do a varicocelectomy. It may improve the sperm retrieval rate. But all these four are not in the accepted guidelines, but the EAU 2024 guidelines is detailing about all these indications, which may be discussed with the patient and discuss with them about the pros and cons. And if they are opting for it, you can do varicocelectomy in all these four situations also. Thank you.
Thank you, sir. Thank you for a lucid presentation on the basics and also the indications of varicocelectomy. I immediately request Dr. Priyank Kothari to start his presentation. Dr. Priyank will also present a video. So since his treatment involves the management also his presentation, so he will present the video along with the presentation, and then we will have some question answers. Thank you. Dr. Priyank?
Yeah, you can hear me?
Yeah. Please share your screen and you can start.
Yeah, I'll share my screen. Good evening, everyone. It was very informative and very to the point presentation by Vinod sir, Dr. Vinod sir. And now I will present, so I'll take over from there and present the other part. The slideshow is visible?
Yeah, very much.
So,
Yes.
yeah, so I'll start.
Yes,
So,
please.
So as we know, sir discussed the indications for varicocelectomy. Now the question arises, what approaches for varicocelectomy and what are the outcomes with each approach, so that it is clear which one to select and which one to avoid or which one has a higher recurrence rate. And I will consider a few special considerations. So I did cover adolescents, so I'll just provide a little bit of evidence of that. So this table I've probably this is there everywhere. So most importantly, in this, we have to discuss the different techniques. That is the open retroperitoneal high ligation or the Palomos technique, which used to be used previously, had a very high recurrence rate. Laparoscopic surgery also has a higher recurrence rate, which owes to the vena comitantes, which actually go around with the after the spermatic vein. And internal spermatic vein and external spermatic vein join, there are certain vena comitantes which go along the testicular artery and join at the level of the renal vein. So they are spared during a laparoscopic surgery, hence the recurrence rate is higher. Inguinal surgery is basically similar to microsurgical subinguinal, but there is a chance we miss some of the external spermatic veins. Again, the recurrence rate is much better compared to laparoscopic, but it is still on the higher side compared to a microscopic inguinal. And with embolization, there is a higher risk of recurrence and technical failure, and it is much more costly. So these are the approaches which we have. Yeah. So what are the best recommendations to summarize for a urologist when we do? So initially, when we start, as I started in my early career, we should start with an inguinal varicocelectomy, 3 to 4 cases. Why? Because it is easier to identify and lesser number of veins. Although the external spermatic veins can be missed, but that is where you start to identify the veins and you start to know how to use a microscope. So that is how you start with the microscopic surgery in the inguinal. And then when you go to the subinguinal microscopic varicocelectomy, there's a lot of advantages because all veins are encountered, so the recurrence rate is less. You can deliver the testes if required when there is a recurrent varicocele or when there are large gubernacular veins, which is debatable whether delivery does benefit. But when there are large posterior gubernacular veins, that can be an option. And it gives best outcomes in the term of small scar, faster recovery, and least recurrence. And also the inguinal area is not violated. Only thing is here, because they require a little bit more experience in this is with the microscope, is because large number of veins and sometimes lesions, occasionally multiple arteries might be encountered. So it requires getting adapted to microsurgery. But once you're adapted after initially starting with inguinal, going to subinguinal microscopic, then it has the best outcome. So, as guidelines have mentioned that AUA ASRM guidelines suggest that varicocele repair has highest success in the by doing a microsurgical varicocelectomy, which is the standard of care. Optical magnification is important because it helps preserve testicular artery and the lymphatics, and hence decrease the chances of testicular atrophy and hydrocele respectively. And the artery can be identified with multiple aids, the operating microscope, using papaverine, by using a microdoppler, or a combination of various factors to make sure that the outcome is best. So even the EUA statement recommendation, the statement states that microscopic approach has a lower recurrence rate and complication rate than non-microscopic approaches, and no RCTs are available for obvious reasons to do a randomized control trial into the two, because laparoscopic procedures are being done generally by a different group of probably general surgeons, and the inguinal and subinguinal are done by microscopic, and it's also difficult to do an RCT, and hence the RCTs are not available, but there is a 2A level of evidence. So these are the operating microscope. They can be with dynamic magnification, where you have continuous magnification, where it is 2, 2.5, 3, 3.5 can be adjusted. And there is other microscopes, cheaper one, which have step magnification. Varicocele definitely can be done with either of them, because in varicocele you do not need to change the magnification much. Generally, you require in the range of 10 to 15x. If it would be a VVA or a VA, it requires higher magnification and dynamic magnification. So for varicocelectomy, a step magnification microscope or advanced microscope also is sufficient. In loops, I do not use loops myself, but in case it's a 4x loop, probably with experience you might know where the arteries and be careful out there. And along with the Doppler, it might be possible, but I would generally prefer a microscope. Microvascular instruments, Jeweller's forceps, micro scissors, micro needle holder to tie the small veins, and the standard set of instruments for any open surgery with smaller the right angle retractor and cat spot to be able to have a smaller incision, and papaverine to identify the artery. This is the microdoppler, which can be used intraoperatively to identify and confirm our artery, because sometimes not only one but 2 or 3 arteries can be identified. So now I will play the video. Fine, I'll play it at the end of the presentation separately. I'll share the screen for the video. So post-op follow-up, immediate post-op instruction should be that there will be some pain and discomfort for 14 days as the veins get thrombosed. Wear tight or new undergarments or a scrotal support, because if it hangs, if the testis is a little pendular, then it causes a little bit of pain, because the veins getting thrombosed is sensitive, and NSAIDs and painkillers should be given in the meanwhile. And for fertility, the follow-up is semen analysis at 3 months. In case of severe OATS, it should be done at 6. And routine follow-up with Doppler is not indicated, but if this to be done, one should look for significant reflux for recurrence. There is a chance of transient improvement with fall in counts in case of suboptimally functioning smaller size testes, or in case of a recurrence. In these cases, you have to be careful, monitor, and we freeze sperm, then we try and do, if you're planning to do ART or any other assisted reproduction, we should do it. The best time would be from 6 to 9 months post-operative. So adolescent varicocele, as sir had already mentioned the guidelines, the thing to understand is adolescents with varicocele are often in the midst of a progressive disease. So we do not know whether the disease is progressive and affecting the testes at which point in the spectrum we are. Either there was varicocele and it has not affected the testicular functioning and it is just there, or it is in the midst of a process which might progress. So it is very difficult to clearly always identify where the varicocele is affecting adolescents and is affecting their testicular function. It is rarely seen in prepubertal boys. They are found in less than 1% of prepubertal boys, but diagnosed in 5 to 30% of post-pubertal 12 to 18-year-old males. And abundant studies have investigated varicocele in adult population, but little data exists on varicocele in younger males. So characteristics are the symptomatic left-sided incidentally noted by a physician or on self-examination. Usually they are large, and usually the patients complain of chronic fullness or swelling in the scrotum and dull pain aggravated in the evening. So most of them are detected during routine medical examinations where the patient might not be symptomatic, and some of them are thus overtreated. And most importantly, the fertility is not proven, and infertility cannot be concluded since it is an adolescent male. The volume should be measured of both the testes, ideally via Prader's or an ultrasound, because the discrepancy in the size of both the testes is going to define if it's a unilateral varicocele, whether we need to intervene or not. Generally, left-sided varicoceles are much more common. So the discrepancy in the testes of size more than 20% or more than 2 on the orchiometer generally suggests that probably there is some impact on the testicular size and function. So one should also look for any pain on palpation, and particularly if the patient complains of pain, we need to ascertain whether the pain is because of a varicocele or not. This has already been covered. So for adolescent varicocele, if the question comes about subclinical varicocele, there is nothing to be done. Usually it is asymptomatic and does not cause any effects. As it is subclinical and no further evaluation or treatment is needed. That is a Doppler diagnosed adolescent varicocele. Well, the most important question is whether a semen analysis is required in an adolescent male presenting with varicocele. This is a very important question because they present at 16 years, 18 years, sometimes 14. So the role remains unclear, and it is not necessary always to do a semen analysis. And even a semen analysis does not necessarily mean that the patient will be fertile or infertile, because it is not going to be a complete marker of fertility. So it is debatable. It is not mandatory. In case of symptomatic varicoceles, prior to planning any intervention, or definitely a pair of semen analysis should be done. And patients who are having a very large varicocele and there is testicular hypertrophy, that time also we would do a semen analysis to see if there is any impact on the semen production. And in cases of adolescent varicocele who have a normal semen analysis initially, we have to follow them up conservatively with annual or biannual semen analysis. If there is any deterioration, we might need to intervene. Hormonal evaluation is not indicated. So the rationale to conservative management is that 80% of adults with varicocele are asymptomatic and fertile, and they are generally not going to be affected even in the long run because of the varicocele, and it is an incidental varicocele. So treating them would lead to 80% overtreatment. Again, asymptomatic males with good testicular size can probably even semen can be deferred, and if it is done, if it is normal, then it is incidental. If there is any change in the semen parameters or decrease in testicular size, intervention can be planned. And the rationale towards interventional management is that in 20% of the patients with adolescent varicocele, there is deterioration in function, and that is where a prophylactic varicocelectomy may be indicated. So to summarize, that important thing which you need to see is that which cases there is going to be a detrimental effect, and in these cases, an intervention would be justified with proper counseling. So a large grade 3 varicocele with ipsilateral testicular hypertrophy, abnormal semen parameters, deterioration in semen parameters, classical varicocele associated pain, and patient choice informed decision. So the pain, if only pain is there, I've covered in the subsequent slides. So the recommendation is weak to treat adolescents with ipsilateral reduction in testicular volume and evidence of progressive testicular dysfunction. There is a weak strength rating, and one should not treat varicocele in infertile men who have normal semen analysis and men with a subclinical varicocele. So summary of evidence, this is the recent guidelines suggests that although the treatment of varicocele in adolescents may be effective, there is significant risk of overtreatment, and in adolescents offer surgery for varicocele associated with persistent small testicular size, which should be confirmed on 2 visits. And outcomes post varicocelectomy will be better when there is catch-up growth in the testes and there is improvement in the semen parameters. And varicocele associated pain improvement is multiple studies suggest different ranges. An appropriate caution should be taken to ensure that patients who have isolated right side of varicocele or have a varicocele that does not decompress in the supine position should undergo ultrasound to rule out any suspicion of mass in the retroperitoneum or the kidney. So one should look for disproportion in the testicular size, and and the grade of the varicocele, and if there is any change in the semen parameter. Now we come to varicocele for severe OATS, and then I will go on to azoospermia, varicocele and azoospermia. So what happens in severe OATS and azoospermia are actually the same continuum phenotypically and genetically, but we have a lot more to do in severe OATS compared to azoospermia, because in azoospermia, in any which ways, we will be requiring a sperm retrieval, whereas in OATS, we have a few sperm in the ejaculate. So if there is any harm, then there could be decrease in the count or maybe absent count. So one has to be careful. Any genetic cause should be ruled out. Higher FSH and smaller testes usually suggest worse prognosis. Higher FSH and smaller testes usually suggest worse prognosis. Improvement in semen parameters depend on the grade of varicocele, laterality, and baseline counts. So, the lower the baseline counts, the worse it is. And counseling is important when we operate such patients, that even if there is improvement, few sperms in the ejaculate, or better improvement from, say, severe, less than 1 million to 3 or 4 million, again, ART might be required. And the target or the aim of treating such patients of varicocele is to improve ART success rates, and occasionally it can lead to downgrading of their treatment to IUI or a natural pregnancy. So here again, after discussing OATS, I discuss this sperm preservation, because in these severe OATS patients, we do not know after varicocelectomy there could be a decline. Particularly, generally in patients with 10 million counts or 20 million, or even normal semen analysis with varicocele, we do not advocate freezing. But for severe OATS, definitely one should advocate freezing, because if varicocele is incidental or not actually affecting the process, it could be an unknown genetic cause, and it could gradually progress to azoospermia. So we miss the chance of freezing sperms. So that is very important. And usually it is not needed for patients with a higher sperm count, but for OATS it is very important, and it's prudent to have reserve sperm, especially if the patient has a high or borderline FSH and severe oligospermia. Also, it is very important to preserve when there is varicocele surgery on a solitary testis, because we do not know any surgical misadventure. Testicular artery might not be injured, but might go into spasm sometimes. And so now after OATS, the next comes in spectrum is varicocele and azoospermia. So varicocele and particularly non-obstructive azoospermia. Obstructive azoospermia is a different entity. We do not try and evaluate or treat a varicocele for obstructive azoospermia unless there is secondary testicular dysfunction. But varicocele and non-obstructive azoospermia, post varicocele surgery, again the most important thing is, why are we doing the varicocelectomy in a NOA patient, non-obstructive azoospermia patient, is that whatever testicular functioning is there, we can improve that. If varicocele is causing some dysfunction or additional dysfunction, sometimes if there is a secondary concomitant cause. So what happens is, post varicocelectomy, a very low sperm count might be attained, which is also a successful varicocele surgery, because those few sperms can be used for ART, and the outcomes for ART might improve. Or sperm may appear transitory, so they need to be preserved, and then again they might decline, because it's generally severely impaired testes, and therefore there is improvement, and then again it can fall over the plateau. If there are any genetic mutations, as further studies are being done, that means that the varicocele surgery might not benefit, because there is an inherent genetic problem, and that is where we do not advocate a varicocelectomy, which could be YQ microdeletion, karyotypical abnormalities, 46XX or a translocation. In those cases, if we find, we should not go ahead with a varicocelectomy. And there are some uncontrolled studies which are showing higher sperm retrieval rates during. So suppose if we do a varicocelectomy, still the patient is azoospermic, then varicocele can be termed a success if during microdissection we find sperms. But for that, where the studies are uncontrolled or the studies are not providing good evidence, is because it is not easy to compare whether actually the varicocelectomy helped or not. There are studies where they have done a TSA before and after, and they have found that sperms have been isolated. So there are a few uncontrolled studies which actually show adequate improvement in sperm retrieval rate. And most importantly, there are few studies which show that those sperm appear sometimes in the ejaculate. There is very likely that they will again come back to azoospermia. So these are the latest studies which are there. There are a few studies in the latest meta-analysis, 468 patients, that with the odds ratio of 2.65, their sperm retrieval rates do increase post varicocelectomy in azoospermia, but the indications have to be selected and genetic causes have to be ruled out. Also, the patient have to be counseled that we are not going to operate for a natural pregnancy. It's going to improve the sperm retrieval rate. Also, a recent update in the sexual and reproductive health has shown a very high rate of sperm retrieval or improvement in sperm retrieval or sperm reappearing in ejaculate in few of the cases. But the quality of evidence is low. As I said, it is very difficult to have a controlled or a randomized study. And risks and benefits of varicose repair must be discussed with the patient, and any genetic or secondary causes which are causing the dysfunction should be ruled out. So what the guidelines say is, although there are no prospective randomized studies, meta-analysis have suggested that there could be sperm appearing in the ejaculate with non-obstructive azoospermia. To summarize, NOA without any genetic cause, large grade 3 clinical varicose with testicular hypertrophy, biopsy pre or during varicose can help prognosticate, because if it is a secondary spermatocyte arrest, it is found that there are better chances of sperm appearing in the ejaculate, or if there is hypospermatogenesis. Assessment should be done for after a longer period, because you need to do more time for recovery. At 1 year, instead of a normal oligospino where we can repeat at 3 to 6 months, ERT is usually required even if sperm appear in the ejaculate. So varicocele repair and pain, is varicocele causing the pain? That is the biggest question. If there's a dull, aching, dragging pain which is aggravated at the end of the day and is relieved on rest, that is the classical pain of varicocele. If there is a sharp shooting pain or pain which is there constantly throughout the day, it is unlikely to be because of varicocele. And an examination will also help us if there is any epidermal tenderness or cord thickening or any sequel of infection, because that could be causing the pain and not the varicocele. So the examination and the history is important to find out whether the varicocele is actually going to be positive for the pain, because there's a dearth of good quality studies. So there are no direct guidelines, but a recent publication in urology annals they studied whether the varicocelectomy is effective for relieving scrotal pain, and they had good data in this study wherein they have seen that the higher grades of varicocele, so they are actually causative of the pain, but the resolution is slightly lower compared to lower grades. And they found that 80% of the patients in their cases, there was either improvement or resolution in pain. The most significant predictor was low grade and bilateral. That is, a lower grade varicocele causing pain had best outcomes, and a higher grade varicocele causing pain had improvement, but outcomes are better with a lower grade varicocele causing pain. That is a grade 2 or a grade 2 clinical varicocele rather than a very large grade 3. However, there are a subset of patients who will not improve, and therefore the counseling has to be very careful. These three studies which have been recently,
Sorry,
yeah,
Priyanka.
this is the last slide.
Yeah, okay.
So undergo varicocectomy embolization, 30% showed complete resolution and 74% showed just reduction in pain. And for grade 3 varicoceles, had complete resolution in 88% of the patients. So pain resolution is better after microsurgical techniques and laparoscopic, and higher with subinguinal than inguinal technique. So that is the basic. I think that to point to the take-home messages, to be very careful in counseling of patients with OATS, with azoospermia, and with pain. These are situations where the counseling is very important. Otherwise, there could be a patient telling that the varicocele has caused the outcome, or the pain did not resolve, or now the counts have gone down. Even pain with varicocele, a semen analysis is very important, and counseling that sometimes the counts can deteriorate. So should I present the video?
Yeah, Priyank, you can make a short presentation, just show the salient steps, maybe 2 to 3 minutes. We have only that.
It's a short one.
We had one question in the comments which Dr. Vinod sir has answered already. If there are any more comments, please add it in the chat box. We will be able to reply it.
I'm trying to find my video one minute.
In the meanwhile, I also invite Dr. Arun Chawla sir to add his comments to the 2 talks and anything extra sir wants to add. By the time
Again, I think there is nothing to add today with the beginning presentation of then followed by Priyank's very erudite presentation. I think no comments, but I have learned many new things, quite a new things. I remember last year when you presented varicose seal with on this topic, and we have understood it as two topics were there. You have also covered very nicely quite a thing. But this our Priyank presentation has made the subject almost to see many members present. So probably this underlines that their practice also they are getting this type of patients who are diagnosed with varicose veins. There's the dilemma in what sort of investigation further to do. There's dilemma in advising, counseling the patient. Nothing is to be done, or which type of varicosectomy or what type of facility they have. If they don't have microscope, what they should be doing. I think if Priyanka can show his video, that will be great. But no comments. Just congratulations to both the speakers.
Thank you, sir. So I'll start with the video.
Yes, Priyank.
So it's a step-by-step approach. I'll try and go quickly. So the incision should be just below the level of the external ring. So this is where the external ring lies. So we'll just
Video is not coming. Video is not
We are
coming.
not able to see the video, so stop sharing again. Start sharing.
okay. Share screen. Video player. Now?
Yeah, you're good. Yeah, perfect.
Yeah. So here we look for the external lingual. That is the external lingual ring, and we can actually invaginate a finger, and yeah, that's the ring. Just below the ring, we'll take an incision so that we directly land up on the cord. So the incision has to be 3 centimeters or 4, not more than that. And we initially do the dissection of the scarpa fascia, go in with right angles, and then we start isolating the cord. The retraction is very important. We can either keep the cord inside or deliver it. Keeping it inside makes it much easier because it reduces the chances of spasm. So here again we found the cord. And we place the retractors. One of the systems will go to the retractor. Now we'll ligate the external spermatic vein. So now the external spermatic vein is generally seen laterally, just to lateral to the cord, along with the external spermatic artery, sometimes very small. You can see it is dilated here, that vein. So this is at magnification of 10x. The cord is just besides, and we actually ligated that external spermatic vein. And now we started dissecting the cremaster. This was the cord, this is inside, not delivered out. And as we dissect the cremaster, we can see there's a lot of fatty tissue, and we can see the veins. So this dissection has to be very gentle, and when you're holding, you should not hold anything very tightly because we don't know where the artery is. So now we have to visualize the cord for pulsation superficially so that we know where the approximate idea where the artery is, so that we can actually isolate that area or that leash. So you're probably seeing the pulsation. Now we'll see the pulsation. So now we have to scan the cord and look for any other veins. I'll show the pulsations will come. So now we'll see this is the vas and the basal vein and the artery. So we let them go separately, and then we start scanning to look for veins. So this is a large vein. The scanning is very important and it has to be done at one level. Otherwise, we'll end up ligating the same vein again. So here, we can bipole, or we should tie with either a echelon 5 or clips are also being used commonly these days. So now actually we are waiting for pulsations here. So the magnification has to be changed. So the testicular artery, there is a leash which is there. So now that is the artery and that is the vein. Now you see, that was the artery. Video has been edited to make it short. So then we are waiting for the. That is the artery on the away side, farther side. Now we can see the pulsation there. Yeah, that is the artery. sometimes you have to be patient while finding the artery. The pulsations because of a dissection can go into spasm. So there we use papaverine. But with experience, you come to know which is the probable artery, and that is where we look for with papaverine or with a intraoperative Doppler. In this patient, I have not used intraoperative Doppler. Ideally, that should be used if you are not very conversant with it. Or if if it's a recurrent varicocele, definitely you require a Doppler. So now we have isolated the artery in the vessel loop outside, and we are tying the large vein which is there. It looks like the 3 to 4 centimeter vein. So tying under microscope requires certain practice for the younger urologists. Younger just pass out. So then practicing under microscope will go a long way. So for the final scanning of the entire cord has to be done, and we should not find any vein, and at least we have scanned 2 times. Otherwise, you'll miss veins, and there's a higher chance of recurrence. And it is better to ligate the veins and cut in between, and some part of the veins should be cut. Otherwise, there is a higher chance of recanalization. So it is better to not, large veins should not only be bipoled. It's better to try and cut. So now we have to make sure we don't damage all the lymphatics, or don't bipole or cut all the lymphatics. Otherwise, we'll end up with a hydrocele. So now I'll show you the lymphatics here. These translucent, how to differentiate is that we put a scissor just below this, and we see that it's a translucent one. We can see the scissor below, beyond. So that means it's a lymphatic. And the veins will be able to not see, and the veins will fill back if we occlude them at one point and let the blood fill, they'll fill back. Now there are small veins just near the artery which forms the lesion. They also have to be bipoled. Otherwise, there is a chance of recurrence. So only the testicular artery should remain at that. Everything has been done at one point, and we could see the pulsations there, so that we don't. If you go at different points, sometimes we might damage the artery when it loops distally or proximally. So it has to be at the same point. Been made faster for the today's presentation. So a little bit of vibration is there. The lymphatics have been spared, and now this is the artery with the pulsation. So we have to confirm pulsations. Sometimes there's spasm, so we can put some papaverine and wait. We close the cremaster over and over the cord, and sorry, we close the cremaster over the cord, yeah, and that can be done with any foro suture. And then subcutaneous and skin are closed with Vital 30, and the skin can be done with the subcuticular monoclinic 30. So it's almost, for a few days, the scar may not be even visible. So this is the scar, and the same procedure can be repeated on the other side. If the patient is obese, slightly, sometimes larger incision is required. So that is it. Now, this is another one, which that's okay. I think covered with most of the steps.
Yes, Priyanka, I think we should stop.
Yep.
Yeah. Okay. Thank you, Dr. Vinod sir and Dr. Priyank for a lucid presentation. I invite Dr. Sujata madam for the closing remarks.
Yeah, thank you, Karthik. It was excellently presented both by Priyank and by Dr. Vinod. And as Chawla sir said, we had a lot of learning points, and I felt like a student, because even andrology is a bit of a neglected subject by me. But anyway, it was nicely covered by you, and thank you very much, Karthik, for arranging this. And I thank all the participants and all the leadership who participated in this program. Thank you and good night.
Thank
you,
you.
ma'am.
Thank you
Thank
all.
you, ma'am. Good night.
Bye.
We have one more webinar on
Karthik.
17th. We have one more webinar on 17th on young
Yes,
bloods. I request
yeah.
them to, yeah.
Yes.
Okay.
You please will circulate it. Yeah. Thanks a lot. Thanks, Navneet. Bye.
Thank you, ma'am. Thank you, ma'am. Bye.